Hello everyone, myself Dr. Prateek Garg, your ENT teacher. Now we will discuss about otitis externa. Let's start with the question. A 60-year-old male presented with a left ear discharge for the last 7 years with a dull earache. Let's read out again. The patient age is 60 years, that is an elderly man. Okay, elderly male patient with the only one-sided ear discharge, that is a left ear discharge for last 7 years with a dull earache. That means my disease is chronic since last 7 years and it is very slowly progressive, because in last 7 years it has to be rapidly progressive. Then patient may have the ear discharge, very severe ear pain and other comorbidities also. So now read next line. On examination, intact TM membrane on both the sides. So my tympanic membrane is intact with discharge coming from posterior canal wall on the left side. Hearing is normal, diagnosis is. Now look at what patient want to mention. Suppose this is my external ear, this is my pinna, and this should be my external auditory canal. Okay, and this should be my drum. Okay, this is my drum. So in the question, the examiner is saying that hearing is normal and tympanic membrane is intact. So that means my pathology is somewhere into the EAC only. Okay, because the middle ear is normal, tympanic membrane is normal and hearing normal. That means disease is not going inside the middle ear, and since it's a chronic disease last 7 years, so it is very slowly progressive disease. So what should be the diagnosis? Let's look out at the option. Keratosis obturans. Keratosis obturans. What do we mean by this keratosis obturans? It is an accumulation of de-squamated epithelium that causes the blockage into external auditory canal. Again, look out at what is this. This is what we mean by keratosis. That is accumulation of de-squamated epithelium. Obturans, that means occluding something. So the collection of de-squamated epithelium occluding the external auditory canal is known as keratosis obturans. We will discuss about this. First, look at the other options. CSOM. I know this can't be there because in chronic suppurative otitis media, TM will not be intact, and plus there will be hearing loss because it is a chronic disease since last 7 years. So in 7 years, CSOM will do decrease hearing plus tympanic membrane perforation will be there. So this is an incorrect answer. Look at the option C, complication of otitis externa. We all know the patient with the otitis externa, they will have severe pain. It will not be a dull earache and it can't go for like 7 years. Otitis externa is so painful that patient usually visit to the OPD and he will get the treatment or antibiotics done. Okay, so I don't think it's a complication of otitis externa which may continue for the 7 years. Okay, so it seems again to be incorrect option. Option number D, carcinoma of external auditory canal. Now, according to me, this option is also incorrect because any cancer anywhere in the body, if it continues for the 7 years, definitely there will be some mass, there will be bony destructions. Hearing can't be normal in any patient with the cancer of ear because in 7 years this carcinomatous tissue will expand, grow, and that will definitely disrupt the hearing, or definitely tympanic membrane will get damaged. So carcinoma can't be an option that is like continuing for 7 years and without doing any hearing changes. So B, C, D, all three options seems to be incorrect, and keratosis obturans is the option which seems to be correct. How this is correct? Let's try to understand what is keratosis obturans. Now, this is a picture of the ear canal where we can see this pearly white brownish color tissue, or we can say epithelium debris is there into the external auditory canal. This is typical picture of keratosis obturans, that is collection of desquamated epithelium. We all know that the external auditory canal wall, it do have the keratinized squamous epithelium. So with the time, this keratinized tissue will get desquamated and will get collected into the ear. So what happens in a normal human body? This collection, this debris or epithelium debris will just come out from the ear by mixing it with the wax. Okay, what happened? The process, the cilia beat centrifugally. So all this collection will come out. Suppose sometimes this ciliary function is hampered, or this growth, it will changes from centrifugal to centripetal, that is going inside, collecting inside. So in that case, this desquamated epithelium will get collected into external auditory canal. So gradually it will cause dull pain to the patient, plus there will be some erosion of the mucosa, some erosion of the epithelium tissue into the external auditory canal. Okay, so generally what happens, it is a bilateral condition. Usually it is seen in young, but it can also be present in the adults or elderly patient. It is mostly associated with the bronchiectasis or chronic sinusitis, because these chronic inflammatory conditions will aggravate this keratosis obturans. So how the patient will present? Patient will present with the hearing loss. That is not because of middle ear pathology, that is because of blockage in the canal. Okay, and patient may have the pain, any sort of discharge, because sometimes bacteria will grow inside this, and patient may have some tinnitus. On examination, we can see a pearly white mass of keratin into the ear canal as shown in the figure. So what is the treatment? Treatment is to removal of this keratin plug. We can remove it either microscopically by the means of suction, or we can do syringing. Okay, in recurrent cases, when the patient is having continuous or recurrent collection of this, so we can use 2% salicylic acid and alcohol that can be used, that will help in clearance of this epithelium. And suppose there is some narrow canal in the patient which leads to accumulation of this debris, so we can go for the canaloplasty, that is to make a proper size of the external auditory canal, so that it may facilitate this debris removal from the ear canal. Okay. Now, again, another term about otitis externa is diffuse otitis externa. It is also known as Singapore ear, swimmer's ear, telephonist ear, or tropical ear. It has been asked in the exam that whenever chronic divers or the persons who are doing continuous swimming, so what happens? This humidified air, or we can say this water, continuously causes irritation of the external auditory canal wall, which will leads into itching, abrasion, and then proceed to some sort of infection. So that is known as diffuse otitis externa. What is the causative agent? Most common is the Pseudomonas. Okay, and what will be the clinical feature? There will be some sort of edema into the canal with the pain and some sort of discharge. How you can treat this? We can look for the anti-pseudomonal antibiotics, because the most common cause of diffuse otitis externa is Pseudomonas. So what are the signs? If you try to pull the external this pinna, so patient will feel the pain. If we try to press this tragal, that is known as the tragal sign. Okay, so that patient will also have the pain. That is the signs of the otitis externa. Okay, so you got about diffuse otitis externa. Let's look out at another question. An old diabetic male patient presented with rapidly spreading infection of the external auditory canal with involvement of the bone and presence of granulation tissue. The drug of choice for this condition is, firstly, read out what patient want to say. The patient is old, elderly patient, that is diabetic, that means somewhat immunocompromised patient, presented with rapidly spreading infection of external auditory canal with involvement of bone and presence of granulation tissue. So by looking at the examiner points which he has mentioned in the question, we all know that this is in case of malignant otitis externa. That means infection of external auditory canal which is very rapidly progressing, plus it is present in the immunocompromised or diabetic or cancerous patient with involvement usually involves the bone, and also the granulation tissues are present. So by looking at the question, I know this is a malignant otitis externa. Malignant otitis externa. Okay, so what is the most common organism responsible for malignant otitis externa? Again, the answer comes to be Pseudomonas. So what is the drug of choice for this condition? Pseudomonas. Generally, what are the antibiotics which can treat the Pseudomonas are either the 4th generation cephalosporin or anti-pseudomonal penicillin group like the meropenem, imipenem, tazobactam, like the piperacillin, tazobactam combination, etc. Or the fluoroquinolones like ciprofloxacin, levofloxacin, or aminoglycosides. So clarithromycin is usually not effective over the Pseudomonas. 2nd generation cephalosporin, they are ineffective for Pseudomonas. And penicillin, if examiner write that anti-pseudomonal penicillin, then it can be the correct option, but it is only penicillin. So generally normal penicillin will not act over the Pseudomonas. So ciprofloxacin, which is an fluoroquinolone, seems to be the correct option. Let's discuss in detail what is malignant otitis externa. In malignant otitis externa, or we can say skull-base osteomyelitis, the infection of the Pseudomonas is spread from the bone or the cartilage of the skull base, and it can spread from the temporal bone towards complete skull base. Okay, it is caused by the Pseudomonas. Okay, and mostly it is seen in like diabetes or immunocompromised patient, or the patient going for chemotherapy like the cancerous patient, because chemotherapy will lower down the patient immunity, self-immunity. What are the symptoms? Patient will have severe pain. There will be granulation tissue in the external auditory canal, usually at the junction of bone and the cartilage. But there will be granulation tissue. That is a typical phenomenon of Pseudomonas. Don't think that granulation tissue will only and only present in Pseudomonas infection. It may present in other infections also, but in Pseudomonas infection, granulation tissues are more 95% times are present. And because it is a malignant otitis externa, that doesn't mean that patient having the malignancy. Where the malignant otitis externa stands for, it stands for like the very rapidly progressive disease which can affect multiple cranial nerves which are present at the skull base, leading to cranial nerve palsy. So in the skull base, suppose there is 9th, 10th, 11th, or the facial nerve, multiple nerves are there, so they may get paralysis or palsy, and usually the discharge will be foul smelling. That is a very bad smell, and discharge will not get benefited with the normal antibiotics. So discharge will be continuous. That is a persistent discharge. Now, which is the most common nerve involved? Answer is facial nerve. It has been asked in the exam. In malignant otitis externa, facial nerve is most commonly affected. Other nerves may be 9, 10, 11, 12. What is the treatment? Treatment is to start the anti-pseudomonal antibodies. Firstly, discuss about the investigation. Firstly, look out for any bony infection sign. Again, CT scan of the temporal bone will be advised, and it is investigation of choice. CT scan of temporal bone. So we will go for a HRCT that will show the skull base involvement of the temporal bone, granulation or disease process going on. MRI, it has its role if the brain or involved or some intracranial complications are there. There are also some radioisotope scans. One is a technetium-99 system EV scan. It can be used for the early diagnosis of the malignant otitis externa, as its intake will be suddenly increased by the Pseudomonas bacteria. So this can be used for the early diagnosis, but investigation of choice is HRCT temporal bone. Now, what is the treatment? First, we will have a biopsy from the granulation tissue to look out whether it is malignant otitis externa or not. And then we can start with the anti-pseudomonal penicillin for 4 to 6 weeks. Now, let's discuss. So this is a diagram showing the anti-pseudomonal antibiotics. So table showing the beta-lactam antibiotic groups, which includes cefepime, piperacillin, tazobactam. We know that the 4th generation cephalosporin are effective against the pseudomonas, but not the 2nd or 3rd generation. So maybe examiner may ask which is the antibiotic effective against the pseudomonas. So 4th generation cephalosporin, that is the cefepime, or we can say ceftazidime. Okay, and what are the other antibiotics? Most commonly what we use for the pseudomonas in OPD or clinical setup is piperacillin or tazobactam. Then comes the imipenem, meropenem group, or the ticarcillin or clavolate. Now fluoroquinone groups also effective against the pseudomonas, that is the ciprofloxacin and the levofloxacin. It has been asked in the previous years that they have given the 4 options, out of that we have to select. So what is the correct answer for the treatment of the pseudomonas infection? So the option given was ciprofloxacin and 2nd or 3rd generation cephalosporin. So correct answer seems to be ciprofloxacin in that question. So just to remember, or just to point out, that fluoroquinones are also effective against pseudomonas. And aminoglycosides like the gentamicin or tobramycin, they are also effective against pseudomonas. If this antibiotic treatment fails, then what we do, the surgery is indicated. In the surgery, what we do is we just debride the granulation or unhealthy tissue completely. We open up the wound and debride all the granulation and the infected tissue. So I hope you got it. Thank you.